see if it Good morning, everyone. And in saying that, I'm addressing both those who are present in the hearing room in Edinburgh and those who are following our proceedings on the live stream. This is the beginning of the fourth session of hearings held by the Scottish Hospitals Inquiry. Two of these sessions related to the Royal Hospital for Children and Young People in Edinburgh. This is the second session relating to the Queen Elizabeth University Hospital in Glasgow. Can I begin by introducing some members of the inquiry team who are present in the hearing room? On my right, there's the lead counsel for the inquiry, Alistair Duncan, KC, and he's immediately assisted by Victoria Arnott, advocate, also counsel to the inquiry, and instructed by Kim Milligan, assistant solicitor to the inquiry. On my left, helping me, is Leslie Brown, again an assistant solicitor to the inquiry. At the first session of the oral hearings in the inquiry, which related to the Glasgow Hospital, we heard from patients and families as to their perspective and their experience. The oral evidence at this session will largely be from frontline clinical staff, mainly, but not only, from the Schiehallion unit and from two managers who were closely involved in the events described by the parents and families. The purpose of this hearing was explained in Council's list of topics for the hearing, and in part, that purpose is to obtain the perspective of staff on the concerns previously identified. In part, it's to highlight areas for future inquiry hearings. Now, witness statements and bundles of documents have been circulated to the core participants, and where appropriate, they are to be found on the inquiry's website. As soon as possible, written transcripts of the evidence that we hear in this session will be posted on the inquiry's website. Other than with my permission, questioning will be by Mr. Duncan. Now, legal representatives will be very familiar with the formal procedure under the inquiry rules, and in particular under Rule 9. I'm not aware of any formal Rule 9 applications having been lodged in respect of this hearing. However, there is the possibility that in the course of Mr. Duncan's questioning, he raises matters or asks questions which legal representatives could not reasonably have anticipated being asked. Accordingly, at the end of each witness's evidence, I would propose that we take a brief break, first of all, to allow legal representatives to take instructions if that is necessary, and secondly, to raise with Mr. Duncan any matters which legal representatives would wish him further to pursue, or alternatively to indicate, and it will be to eventually to me, if legal representatives themselves wish to put questions. So there will be an opportunity to explore, first of all, with Mr. Duncan, and then, if necessary, more formally with me, in the event of unanticipated lines of evidence having been opened up. Finally, can I remind everyone, particularly in the room, that, as I've previously said, these proceedings are live streamed and recorded for the purposes of sharing with the wider public. That inevitably means that there is the possibility that anyone in the room will be recorded and seen on the live screen, of the live stream rather. Now, there's nothing that I intend that occurs to me that I need to raise this morning, and accordingly will hand over to Mr. Duncan, who may simply wish to lead his first witness.
Thank you, my lord. That is indeed what I intend to do, and the first witness will be Professor Brenda Gibson.
Thank you. Please sit down, Professor. Good morning, Professor. Good morning. As you appreciate, you're about to be asked questions by Mr. Duncan, the counsel to the inquiry. But as a first step, I understand you're prepared to take the oath.
Yes, I am.
Could I ask you just to sit where you are, raise your right hand, and repeat these words after me. I swear by Almighty God.
I swear by Almighty God.
That I will tell the truth.
That I will tell the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Thank you very much, Professor. Can I just say that I would propose that we will take a break during the course of the morning, perhaps around about 11:30. It just depends where we find a natural break. But if at any time or for any reason you wish to just take a break in your evidence, simply indicate that to me and we will take a break. The other thing is, I'm very conscious of this because I'm hard of hearing. I don't know if you can see, but I wear hearing aids. And they are excellent, but they're not perfect. So not necessarily easy to do this, but could I ask you maybe to speak a little more loudly than you would in normal conversation? The microphone should help, but if you could just bear in mind that I certainly need all the help that I can.
Try.
Mr. Duncan.
Thank you, my lord. Good morning again, Professor. What I'll do in asking questions of you this morning is, first of all, I'm going to ask you some questions about who you are, and then I'm going to ask you some questions about who your patients are, and then we'll start to talk about the issues with the hospital. So if we can just take things in that order, could you just begin by perhaps giving us your full name?
Brenda Elizabeth Simpson Gibson.
Thank you. Now, in line with what His Lordship has just said, I wonder if we could maybe have you a wee bit nearer the microphone. Do you want to just slide it? I have the same problem, and I don't know whether actually at the minute I'm perhaps deafening everybody in the room. I'm getting shakes of heads. So we'll proceed in that way. Are you, am I right in thinking you're a consultant paediatric haematologist, is that right?
I am, yes.
Yeah. And where are you based?
The Royal Hospital for Children in Glasgow.
Thank you. What positions do you hold currently with Greater Glasgow and Clyde Health Board, or indeed elsewhere?
Well, with Greater Glasgow Health Board, I am a consultant paediatric haematologist, an NHS employee, and I have an honorary professorship from the University of Glasgow.
And are you the lead clinician?
I am the lead clinician.
Of haematology and oncology, is that right?
I'm the lead clinician within the department, and I'm the director of the bone marrow transplant programme.
Yeah. So are you in charge effectively of the provision of the West of Scotland paediatric leukemia service? Would that be right?
Mainly, yes.
Yeah. And departmental lead for systematic administration of chemotherapy, have I got that right?
Yes.
And director of the National is it allogenic?
Allogeneic bone marrow
Allogeneic.
transplant program.
And I'm probably going to mangle this one as well. Is that a form of hematopoietic stem cell transplantation?
It is hematopoietic stem cell transplant,
It is.
yes.
It's not a form of it, is it?
It is it.
Yeah.
I
Is
mean,
the other form of...
stem cell transplantation and bone marrow transplantation are anonymous. They're the same, yeah.
Thank you. Now, you've set out very helpfully in your statement a no doubt potted history of your CV, and we will look at that carefully, indeed have already. I've got one question for you. Why haematology?
For me, why haematology and why paediatric haematology? Well, it is a specialty. Well, there's several things. Certainly when I trained, it was a mixed laboratory and clinical specialty. And I found it attractive that you could make the diagnosis yourself without being dependent on a pathologist or a radiologist or a surgeon or anybody else. So I think that is an attraction. But primarily, you know, these are families that are children and their parents, so the families that we will meet. We will know them for... If this is a leukemia, you know, we may treat them for 3 years. We have very good relationships generally, you know, with the families, and I personally get a lot out of those relationships.
It's obvious from the evidence we heard in the autumn of 2021 that some of those experiences will be very hard and upsetting, but
yeah.
are you indicating that there are also rewards from all of that as well?
Sorry?
There are rewards?
There are enormous rewards.
Yeah.
It's a huge reward. You know, I've done it so many years now that the children that started off with me are now adults with their own children. And it's a great reward to see that coming back. I look around my department. I treated some of the nurses in the department, some of the place specialists. There's a few consultants within the hospital that I've had as patients. So it is a very rewarding specialty.
Thank you. Now, at some point in your career, I think we detect from your statement that you began to focus upon malignant conditions rather than benign. Is that right?
Yes.
But are we right in understanding that the department also does look after children with benign
So
conditions?
the department will look after any cancer and any haematology, any blood problem. So we'll look after all the solid tumours, we'll look after all the leukemics, we'll do the transplants for Scotland, we'll look after the children with an increasing number with sickle cell anemia, clotting problems like haemophilia, and all the benign anemias and thrombocytopenias and all the other things.
Thank you. Now, that really neatly takes us towards having you tell us a bit about the patients, which I said I would ask you to do next. But before you do that, I wonder if you could maybe just explain something further about your role, your professional role relative to the questions that this inquiry has to determine. Now, let me just explain what I mean by that. The inquiry is tasked with finding out whether the hospital building at which you work provides a suitable environment for the delivery of safe, effective, person-centred care. And I guess I would be interested in understanding what, if any, responsibility the clinicians have to the provision of the building.
I think I can be very clear about that. It's something that's been talked about many times in our department, by myself and my colleagues. Our view is that we as clinicians are responsible for providing chemotherapy or any other form of care within national or international protocols or guidelines, and to do that with a well-trained workforce within a holistic manner. The responsibility of providing a safe environment for that treatment to be delivered lies, in our view, with the health board led by the chief executive. Right. The responsibility for deciding is a place safe or not safe lies with control of infection.
Thank you. So if we move on then from there, Professor Gibson, then, as I indicated, I would like to just find out a little bit more from the clinician's perspective about the patients that you look after. You touched on some of it already. Let's begin then with thinking about the range of patients. You've mentioned there's a range of conditions treated in the unit. If we take the malignant conditions, what would the range be? What sort of conditions would you see?
Well, within the unit, we would see all kinds of malignant disease. I mean, if they live in the west of Scotland, they come to us. We are their tertiary referral centre. So I think, for me, as you've already said, I have specialised, or I have contracted down what I do to leukemia and transplant. So if you look at children with cancer, which is not the bulk, we're increasingly seeing lots of sickle cell disease in the west of Scotland because of migration issues. But for me, if you look at cancers, you can kind of divide them into a third are leukemias, lymphomas, a third are brain tumours, and a third are a mismatch of other things like neuroblastoma, rhabdomyosarcoma. But, for me, the bulk that I look after has been the leukemics and the transplants.
Thank you. At any one time, how many inpatients would there be on the unit, do you think?
Gosh, we just changed this when we moved back. I think we have 23 beds. Yes. And
it may or may not be possible to even give an approximation to this sort of question, but to what extent would those beds usually be completely filled?
They're usually filled.
Yeah. And as far as the split between those having chemotherapy and those who are in for bone marrow transplant, what would be the split there?
We would see for leukemia, I think I can probably answer best for leukemia, we would see 20, 25 new cases a year. We are commissioned by NSD, the National Services Division, to transplant about 15, 18, up to 20 transplants a year.
Yeah.
However, as well as numbers, intensity matters. Now, because the intensity of transplanting somebody is significantly greater than the intensity of just delivering chemotherapy.
Indeed. I'm going to ask you in a moment a bit about treatment, including transplanting. But at any one time, very roughly, how many transplant patients would there be on the ward?
There's 3 in at the moment.
And would that be typical?
Yeah. Sometimes there might be 5 or 6.
And again, and I'm only interested in approximations, what would the size roughly of the cohort of outpatients be at any one time?
Large. So several hundred, is the answer to that. We will treat leukemia to begin with until they go into remission within the ward. They'll then only be seen as outpatients. So it's not really outpatients. Some come to the outpatient clinic, a lot come to the daycare unit. So the daycare unit might see 20, 25 children a day.
I mean, you say the daycare unit, are you speaking about 2B?
2B. Yes, 2B.
I want to move on then and just perhaps ask you some questions about the treatment of the conditions that you look after. Very broadly, what are the stages of chemotherapy?
Well, that depends what disease you've got.
If we maybe then just focus it on, say, leukemia.
Okay. So the stages of chemotherapy for leukemia, the first thing you have to do is achieve a remission. So if you look at leukemia, 85% of them will have what you call childhood leukemia, acute lymphoblastic leukemia, which is the predominant type in children, and 85% will have that. 15% will have acute myeloid leukemia, which is the leukemia you more often see in adults. And sometimes they're called childhood leukemia, in adult leukemia, because of the age predominance or distribution. So the first thing, whatever you do, whatever kind of leukemia you've got, you have to achieve remission. So you have to clear disease. So if we take acute lymphoblastic leukemia, which is the commonest cancer we see, then they have 4 weeks of chemotherapy to achieve remission. They will then go on and have a number of blocks of chemotherapy which can be delivered in the daycare unit or as an outpatient of varying intensity, dependent on the response to the first 4 weeks. And once they've completed those, which will take 4 to 6 months, they will then be treated on what's called maintenance treatment, which is all outpatient based, and they're almost back to normal life by then. And that has always been 2 years for girls. It used to be 3 years for boys. It is just now reduced to 2 years for boys on the current national trial.
Thank you. Now, what about bone marrow transplant? Are you able to give us an indication of what the stages of that look like?
Well, in terms of a lot of things that might come up in the inquiry, leukemia, somebody with leukemia presents to your emergency department or via their GP, and it's an emergency admission, and they have to be treated within, well, dependent on a number of factors, either that day or within 48 hours, 72 hours. There's a lot of planning goes into transplantation. First of all, you have to, dependent on what you're being transplanted for, and we don't just transplant children with malignant disease, we transplant children with benign, disease as well. So there will be criteria they will have to fulfill to be eligible. And there is a UK-wide BSBMT guideline on who should and who should not be transplanted. And that's very important because transplantation carries a significant mortality. So you should be very clear in your mind that there's no alternative option which would give you equal or better results, then that is the best. So first of all, there's a lot of planning goes on. You confirm or agree that, and we would do that within a multidisciplinary team. No one individual would take that decision. We do that within a meeting. We'd all agree this is the best way forward. If there was any question or not, we would take it to a UK-wide monthly transplant MDT where we discuss it with our colleagues up and down the country. Once we've decided, and you have to identify a donor. Now that can be very difficult not very difficult, I shouldn't have said that, but that's quite complicated. If your chance of having a brother or a sister, assuming you have the same father, is 1 in 4. So the vast majority of children do not have a sibling, donor. So we're looking for donors on national panels. And for the UK, we work through the Anthony Nolan panel, who then interacts with the equivalent in the States, the equivalent in Germany, the equivalent in other countries. So you have to identify a donor, and that can take quite a long time because we will have the tissue type of the patient that will be sent to the registries. It will then all have to be confirmed. Once you've identified the donor, you then have to set a date that the donor is willing to donate on, which gives you an idea of when you can plan that transplant. So to go to transplant, you have to give them what is referred to as conditioning chemotherapy or radiotherapy, dependent on their disease, where you wipe out the bone marrow and any disease with it so that there is something for the donor cells to then engraft in. Now that can take 10 days to give that conditioning chemotherapy. You then sit and wait for the marrow to graft. Now that can depend on the donor source. That can take a variable length of time, but you're talking on average 3 to 4 weeks. Then you have to cope with the complications of what you've done, and that can take several months or a number of months.
And do those complications include the potential of a reaction between the graft and the host, as it were?
Well, infection is the first complication, which is why there is guidelines on where and how you nurse these. So initially, the first well, there are many complications of transplant, which is why we give great thought to who goes ahead and who does not go ahead, and to try and predict a mortality, rate, so that people can fairly and informedly, consent. But I don't know if anybody can ever consent to something like that, if we're really honest. Yeah. It does require a lot of understanding. So yes, so the complications are infection, graft versus host disease, which is what you're saying, react. You can get organ damage. You can have all the complications of the conditioning, drugs, but I suppose infection and graft versus host disease are the biggest complications we see.
Yeah. And in terms of planning a bone marrow transplant, did I take from what you said a moment ago that what that looks like very much depends on the individual patient case and indeed the situation as regards the availability of a donor, is that right?
Well, in Scotland, we have a weekly MDT that we, through teams, that we, so it's a multidisciplinary team meeting where we meet our colleagues from Edinburgh and Aberdeen and Dundee and Inverness on a weekly basis. They will alert us to any patient who they think may require a transplant. It's not that simple because whether they do or don't may depend on how they respond to frontline chemotherapy. So it can be a bit of a waiting game, to know what's going to. But as soon as we think it's likely, then we'll start looking for a donor.
Can the requirement for a transplant be something that arises quite suddenly?
Yes, there are some children that are born with problems that have to be transplanted quickly.
Yeah.
Yeah.
An indication that we've had from one of the statements provided by one of your colleagues suggests that there can be quite a narrow window to get to a bone marrow transplant for some patients. Would that be
Yes,
right?
if you're transplanting somebody with relapsed disease, for example, relapsed leukemia, and it has been difficult to achieve a second remission, then, you've got your time limited to get to transplant whilst you can maintain that remission.
Yeah, thank you. Now, you mentioned infection, and I'm going to ask you in a moment some questions about the risk of infection for patients going through chemotherapy and transplant. But before I do that, I wonder if it might be worth just having you offer your own reflections on some of what the patients and families said about just the treatment of cancer and leukemia and the like. And they described treatment as something that could be grueling, unpredictable, have terrifying side effects. Are these descriptions that you would recognise?
Well, when you get the diagnosis of cancer in your child, it changes your life. Your life's never going to be the same. It's never going to be the same for you, the child, the siblings, or any of your relatives. It doesn't really matter. Well, it does matter, of course it matters. But, I think the fear that children will relapse or not respond to treatment never leaves families. It doesn't matter how much, we as clinicians can say this is very good risk disease, the relapse rate is very low, and once you get to a certain stage post-treatment, almost nobody in trials has ever relapsed. You can say that, but it's okay to say that, to be receiving that, and I don't think the fear ever leaves, families, whatever. So I think they live with that fear, and that is quite grueling. It is very difficult to watch your child. They all have central lines put in. We understand the benefit of them, but it isn't. For parents, particularly of any child, it is hard to watch them go to theatre for lines, for bone marrows, for lumbar punctures. It's hard to see them, change as children. They often say that they're not the child they were before, or they're back to themselves, because it's hard to see them not eat. It's hard to see them lose their hair. Yes, it is. It is grueling.
Now, let's maybe move on, and as I indicated, perhaps have you offer some observations in relation to infection. Now, there's quite a bit in your statement already about this, but I think it would be worth having you provide some evidence today about it too. To what extent are your patients susceptible to a risk of infection?
They're very susceptible to risk of infection. So what stops you and I from getting the kind of infections they get is three things basically. Our bone marrow makes 3 cells. It makes red cells that if you don't have enough, you're anemic. It makes healthy white cells called neutrophils, and the job of a neutrophil is to protect you against bacterial and fungal infections. And these are the infections that we are really concerned with here. And it makes little cells called platelets that stop you bruising or bleeding. So your main defense against infection is having a normal or at least an adequate neutrophil count to deal with infections. The second thing that matters is having integrity of your epithelium. So if you ulcerate your mouth or ulcerate your gut, we're all colonized with bugs. And if you breach that epithelium, then there's the risk of the bugs from yourself, going into your bloodstream and making you unwell. And I suppose the third thing that makes you susceptible is you've got a bit of plastic in you. You've got an indwelling central line that bugs can sit on. So if we look at the children coming through our unit, this was very reflected in the case review study, the deeper your neutropenia, so we'll call anybody with a count of 1 × 10⁹ per litre neutropenic. If you've got none, which absolute neutropenia, or you're less than 0.5, the more profound the fall in your neutrophil count and the longer it stays low, the greater your risk of infection. That's also compounded if you have drugs that suppress your immunity. And perhaps the most suppressing of the drugs that we use commonly is steroids and leukemia.
So you have anticipated my next question, which was going to be whether there's a range of susceptibility.
Yeah.
And I take you to suggest that there is. And would it be those who are profoundly neutropenic who would be at the most susceptible end?
The most susceptible are the transplants, because you've given them much more intensive chemotherapy than you give anybody else. So you've broken down their mucosal lining and you've allowed bugs to get in. They will be profoundly they will have an absolute neutropenia, so no cells at all, maybe for 3 to 4 weeks. You've also given them very impressive immunosuppression to prevent graft versus host disease. So you've given them cyclosporin or MMF or tacrolimus or something that suppresses their immune system. Then if they get graft versus host disease in itself is immunosuppressive. So, they are the most vulnerable, followed by relapsed leukemia. And the reason they're the next most vulnerable is they've already been hit by one lot of chemotherapy. And that's taken its toll, and relapse treatment is always more intensive than non-relapse treatment because you already failed, the lighter treatment, followed then upfront acute myeloid leukemia, then followed by ALL. But there are patients within those that would be particularly susceptible. There's a much higher incidence of leukemia in children with Down syndrome. They have already got immune deficiency as part of their Down syndrome. So they're particularly susceptible, and babies are particularly susceptible.
Thank you.
Then the solid tumours, which I shouldn't probably talk about, but they will, if their bone marrow is affected, they're in the same position. But for a lot of them, that's stage 4 disease, they don't have involvement of the bone marrow. And they will tolerate chemotherapy much better because they just have intermittent periods of neutropenia.
Thank you. So thinking about what you've just said, from your perspective, would you see the work of this inquiry as being around the incidence of infection other than what might be anticipated as a result of the issues that you've just described?
Yes, I would say so. Within, I know we're going to talk about prophylaxis at some point, but, wherever we can, we treat children on national or international trials. That gives you a prediction of what the risk of infection or the risk of toxicity is. I mean, I know it's, we do use some terrible terms that are awful when you say them out loud, but we do talk about treatment-related mortality, which means your chances of something awful happening, during chemotherapy. And we will have that for most in diseases from previous experience of what's happened with children similarly. Now, the best is is the leukemia data probably, and before coming to this, I did check with the chief investigator of our last trial. The induction death rate from infection was 0.7%. The death rate later on was 1.3%, so the death rate in total was 2%. I can say I've gone back over the last 10 years of our data for leukemia, and we didn't have a single death from infection of children treated with chemotherapy alone. I'm not talking about transplant patients.
Thank you. Now, some of this you've already touched on, but I wondered if it might be helpful just to have an understanding of the pathogens that might cause infection. It might make the remainder of your evidence easier for us to understand. There's a difference I think you've touched on already between endogenous and exogenous, is that right?
Yes.
And when you were speaking earlier about infection coming from inside the body, that would be endogenous.
Endogenous, yes.
And you've I think already answered this question too. I was going to ask you to classify the pathogens that are of particular concern to you, and you would say it was bacterial and fungal would be the main
Yes.
ones?
Yeah.
And as far as bacterial is concerned, are we to understand that those can be divided into gram-negative and gram-positive?
Yes.
Yeah. Are we right in understanding that the latter, gram-positive, are often associated with line care issues?
Yeah, I mean, they're often, they come off the skin.
Yeah.
You know, they're staphs off the skin, and they're often line care issues. And we would, not all of them, I mean, staph is not that we wouldn't worry about a coag-negative staph, but some streps can make you quite ill. But, you know, it's gram-negatives that we direct our empirical treatment against.
What is empirical treatment?
So if you have no neutrophils and you come, all our parents are taught very well before they go home that if they have their child has a temperature of over 38 or over twice or 38.5, that they contact us and they come back. So if we have a child who has a temperature and who is neutropenic, we don't wait for the blood cultures. We treat them empirically. So we choose the antibiotics to make sure they cover the organisms that are most serious and would make them most ill. Mm-hmm. So we have an empirical antibiotic regime.
And is it gram-negative infections?
They are aimed at gram-negatives.
Yeah.
They will have some gram-positive cover, but they're not particularly directed at the kind of things that go in through a line.
Yeah, and is it
gram-positives that go in through a line?
Sorry. And is it gram-negatives that have the potential to be a particular danger to your patients?
Yes, particularly those that can form a biofilm.
Now, you've also anticipated something else I was going to ask you about, which was getting us towards the question of communication. And I wonder, given what you just said, whether you'd be heartened to hear that I think almost all the patient and family witnesses said that one of the things they understood right from the start was the biggest threat to their children was infection.
Yes. I can say that, for example, I can give you an example of why they will understand that. If I take acute lymphoblastic leukemia, which is what I always take, the chance of a child going into remission, and that's what the families want to know. You know, you're saying to them, we're giving you 4 weeks of treatment to clear disease, and that's called a remission. And then the rest of the treatment you'll get is going to be to get rid of rogue cells that are left behind that we can't see. So the chances of, if they say to me, what's the chances of that? I will say it's 96%. And then if you turn that around and say what happens to the other 4%, well, half of them will have unresponsive disease, and they will tend to be the teenagers with bad cytogenetics. And the other 2%, I've told you, will die from infection. So, you know, that is drummed into them from the very beginning. So it's understandable how scary infection, you know, is for them. Before they will go home, they are taught how to take a temperature. They're told when they contact us, and they don't quite sit an exam, but we do have what we call a discharge protocol, that where there's the significance, and it's made very clear to them they don't ignore temperatures.
And you also anticipate my next question about another thing that they emphasised was how scary infection could be, and we heard some very upsetting descriptions of episodes of infection. Would that be your experience too, that it's something that can happen very suddenly?
No, it can happen very suddenly. That's why we use empirical antibiotics. We have a policy of how fast those antibiotics have to go in.
Yeah.
You know, and you have to see it in the light of the context. If you are a good responder, and at least half the children will be good responders with ALL, the relapse rate sitting national around the world, the last trial was 3.7%, it's sitting at 4% around the world. So of those who do relapse, half of them will be salvaged. So the overall survival is 98%. So that is equivalent to your chances of getting a untreatable infection. So it's not that the numbers are necessarily high, but relatively speaking, the outcome of having an infection or a fatal infection like that is very significant when you put it into the context of a disease with that kind of survival rate.
Yes. Now, one of the things that many of them described in the context of infection episodes was something, and I'm still not clear how we pronounce it, whether it's rigor or rigor.
Rigor.
Could you tell us a bit about that, please?
Well, I don't know if you've ever had the flu or if you got COVID, but when your rigors, when you shake, and that's really when your blood pressure, if you get bacteria going into your bloodstream, it will put your heart rate up, it will drop your blood pressure, and you feel shivery. And so they're really describing what it's like having the flu.
Their descriptions of it, I think, were something more dramatic than that.
No, you're right. They are more dramatic, but that's what a rigor to URI is.
Yeah.
When we have that, they can have very significant rigors. Yeah, they are right.
Okay. And in terms of other impacts from infection, I think this is all in your statement, so we'll take this fairly quickly. If we may, additional surgery would be one possibility if a line needed to be replaced. Is that right?
Yes, if we will always discuss with microbiology, does the line come out, does the line stay in? If it's an organism that's known to cause a biofilm, the line will definitely come out.
Yeah.
Nowadays, we will discuss with control of infection every gram negative and decide, does the line, what is the likely source? Is this likely to have been endogenous or exogenous? And then take the decision, is the line removed or not?
And delay or cancellation of treatment, would that be another possibility?
Well, you have to get over the infection. You can't give somebody chemotherapy who's still infected. So you have to clear the infection and you have to get the line back in.
Now, just moving towards the conclusion of this discussion about infection, again, just thinking back to this question of what you would see your role as a witness in this inquiry as being, can you say whether it would be your view that expert analysis of infection patterns would be for treating clinicians or would be for microbiologists and epidemiologists?
I think it's for microbiologists and epidemiologists, and indeed statisticians, perhaps.
Mm-hmm. I wonder if, as treating clinicians, your experience does at least permit an informed view of whether at least infection patterns are or are not what you would normally anticipate.
Well, as treating clinicians, we may feel that we're seeing more infections than we usually see. We did, in this occasion, feel that they were unusual infections. They weren't. If there were spikes, they weren't spikes across the board. But it is for us to say to the control of infection, is this okay or is this not okay? It is for them to decide. We're not experts, in that field, and we often have concerns that are not founded.
Thank you. Now, something that you raised a moment ago also was the question of prophylaxis, and again, you've dealt with this quite extensively in your witness statement. So, if we may, I might try and take this fairly quickly. Are we right to understand that the provision of prophylaxis to patients is something that happens as a matter of course?
It is something that happens as a matter of course for some patients. Yeah. So, we recognise the risk of induction in ALL with high-dose steroids. We'll prophylax against fungus for that. We recognise that children with Down syndrome are a particular risk. We recognise infants are. So there are criteria that within national trials where there is a guideline as to what you do, and we would always follow that guideline.
Yeah. And what would the conventional approach be to communicating with patients around the provision of prophylaxis? Well,
if they were a newly presenting patient, we would go over that the same way we would go over the chemotherapy with them. It's not just, they're all prophylaxed against pneumocystis with Septrin for the entirety. The parents know that. And they will know what prophylaxis they're having at any one time and why they're having it. But to be honest, when you first come with your child with leukemia, that's not your main concern.
No. Now, another thing that the patients and families spoke about and which you speak about in your statement is the bond of trust between the clinician and the family. How important do you see that
I think it's incredibly important. Families have to trust you. I mean, there has to be, we often say that the families are part of the team. There's only one side in a team, and there has to be trust within that team, or else you can't really move forward. We have to also accept that, we are in 2023. The days of thinking that doctors always know best are over and done with, and you have to earn trust as you have to earn reputation. And it's right and proper that they ask, if they have queries or they have doubts. But trust is immensely important.
How important is effective and open communication to the development and maintenance of trust?
I think it's very important to do it. I actually do think we communicate well with families, spend a lot of time doing it. And it's not just the doctors who do it. Nurses are going in, we're going in on a ward round and speaking, well, you're meeting them at the beginning, but you're going in every day on a ward round and meeting them. And, if they're having chemotherapy, there's nurses going in and out all day that they're asking questions of. They're then going to daycare and they're asking, and they're having the same advice or the same opportunity to ask questions, go over them. It's not a one-off thing, communicating with them about what the problem is or what might happen. And we have lots of very, very senior nurses. We have advanced nurse practitioners within most specialties, so within most divisions, and they will phone them all the time. We have a triage phone that they can phone for any advice at any time. It's not a one-stop. Communication is ongoing, and it doesn't stop.
Moving on then to start to think about the hospital then. You set out in your statement briefly the history of the Schahalian unit. I wonder if you could just give us a thumbnail sketch of how the Schahalian unit came about.
Do you mean how we got the name? Or
yeah.
Oh God, right, okay. So we opened the Schahalian unit in 1996. It had been the Department of Child and Family Psychiatry, so it was a large area. It was a very good flow plan for us, and we had, previous to that, we had shared a ward with general paediatrics, and it's a bit of deja vu for me because general paediatrics would admit, we didn't have cubicles at that time in that ward. It was open plan and would admit children with infections, which would then spread to our children. So we had a very good campaign to get the hospital to allow us to move to a standalone unit, and the standalone unit was Schahalian. Lots of things were different in those days, and to be honest, I can't remember most of them. But I'd worked for a long time with the ward sister, and I think we drew the plans up ourselves. I think the advantage of it was, or the aim of it was, that it was very inclusive towards the team. So not just it wasn't just about patient accommodation, and the parents had a suite on the ward. We had, I think, if I remember rightly, 3 bedrooms, a kitchen, and a shared toilet. So it wasn't luxury, it wasn't the Hilton, but it was very functional, and it did mean that if their child was unwell, they had somewhere they could go and sleep for a few hours without being awake all night with people coming in and checking temperatures and reading drip stands and, things like that. But on the other hand, they didn't have to leave the hospital, so they could come back in a hurry if they wanted to, or even if there was nothing wrong, but they just needed that reassurance in their own mind. So we had parent accommodation, we had good accommodation for the children. We brought down our transplant cubicles from the ward. We had office accommodation, and that office accommodation was for medical staff. We had social work, we had our outreach nurses, we had our data management, we had everything that you need to run an effective unit, and it was all very close by. It was very easy for families to just come along. You hadn't gone home at night and knock on your door and sit down and talk about something. They could access social work very easily. We had a staff room, so communication wasn't the difficulty it is now, because we actually spoke to each other in a staff room. We had a seminar room that we could hold all our meetings in. So, we had a very compact unit, which I think allowed the delivery of holistic care. We would have outgrown it. I'm not saying we wouldn't have outgrown it, because as staff increases, you always outgrow. But it offered us everything we needed at that time.
Thank you. Now, I'm going to move on then and think about the move from York Hill to the new hospital. And I'm going to ask you some questions about the involvement of clinicians in the planning of that, and indeed in the relation to the construction of the hospital. Now, these are probably more questions that we'll look at in another hearing, but I think it would be useful to hear your evidence on these matters now. You summarise it to some extent in your statement, but I'm just going to ask you a few questions about that. And first of all, to what extent were you and clinical colleagues consulted with as regards relocation of the hospital, or as regards the layout of the new hospital?
Well, the relocation of the hospital, we weren't consulted at all. I don't know if we'd any right to be consulted, in fairness. My understanding, which may or may not be correct, is that we moved because for much of my time on the York Hill site, there was the Queen Mother's Hospital, which was a maternity hospital. It did not meet national standard. I mean, I don't know if that's the right term, but you're meant to have an intensive care unit on the site of a maternity hospital in case of acute bleeds or bad postpartum or antepartum hemorrhages, and where our mothers had to be stabilised and taken to the intensive care unit at Gartnavel, site, or maybe the Western, I can't remember, but certainly off site. And so there was an option appraisal done to see which of the maternity sites would remain. We had at that time what was called Rotten Row, the one at the Royal, the one on the Southern General site, and the Queen Mother's. And it was decided there would only be two, and so they moved the Queen Mother's to the Southern General site, where there was an adult intensive care unit. And that was in some ways the reason for moving as I understand it, never involved in it, the Children's Hospital, so that the neonates, the babies would be in a paediatric setting.
Thank you. And as far as, after that decision is taken, as far as what the layout of the new Schiehallion unit would look like, to what extent was there consultation with clinicians around that?
Well, my recollection is there was very limited consultation. I do remember going to a number of meetings with my consultant colleagues and some of the senior nurses within the unit. All that I remember we had as choices was there was a floor plan, and that was to be our space. And we were not to have any more space than that. We could do anything we liked with that space, but if it didn't meet our needs, it couldn't be extended. So we just had to make the most of that space, and we opted to maximise the number of patient cubicles, because we quite frequently boarded patients out, and I think you heard from the families how much they hated getting sent to another ward. So we wanted to do everything we could to avoid that situation. So, we had to just accept that we sacrificed much of what we'd had in the old Schiehallion unit. So the things like we lost all office, with the exception of the nurses who work on the ward. I mean, I think people sometimes get confused about who actually works in the ward. Doctors do ward consultants, they go to clinics, they go and, so they're not permanently on the ward the way a nurse is permanently, on the ward. So in some ways, the distribution of space or the allocation we left to the nurses, but we lost office accommodation, we lost the patient-parent accommodation, we lost our staff room, we lost our seminar room, our pharmacy accommodation. I have always said in my statements and repeatedly say was grossly inadequate, and pharmacists are enormously important in a unit such as ours. This is not an adult where you give 500 milligrams 4 times a day. Everything is calculated on weight, and going into lots of fluid that have to be very carefully calculated, particularly for small children. So they're enormously important. So we lost a lot. In terms of where everybody went or how the space that we were being allowed was used, we left really to the nurses. They were in a far better position to say where the sluice needed to be or the preparation room needed to be compared to the patient cubicles, because they were the people using it. I, as the lead, was asked to sign off the plan, and I didn't do it. But I didn't do it to the best of my knowledge. I certainly held out for a very long time. At this inquiry, I always feel that I'm going to get shown a bit of paper with a signature, but I'm almost certain I didn't do it. And I held out for and I think it was signed off by a senior nurse, a managerial nurse. That's my understanding. And I didn't do it because particularly there was no parent accommodation, which I thought was, when I say no parent accommodation, there was a bed in the child's room, but there was nowhere to go make a cup of coffee. There was no coffee room. There was nowhere the parents could sit down together, and they do get a lot of support, from each other. I thought pharmacy was inadequate, and I thought it didn't, we had been promised a like-for-like unit in a flagship hospital, and it certainly wasn't a like-for-like, unit. Now, if you're asking me, were we involved in the ventilation or the water or the anything like that? No, we had no involvement in that. Our involvement was purely in deciding how we would allocate the space.
Thank you. Now, just one further question around that. In your statement, you described the process of consultation with clinicians around that as extremely unpleasant. What did you mean by that?
Well, we did try to argue our case, as you can imagine. We did, and it did get rather heated. But we didn't win. There was a very firm line taken. What we did do was I did manage, must have been before we moved in, I honestly can't remember, to persuade the local management to convert a room, which I cannot remember the purpose of that room, into a small kitchen for the parents, that they could, have a microwave and make a cup of coffee and sit down. And that was achieved. We have off-site accommodation for families in, they keep changing their name, and I never remember what they changed their name to, but it was Click, Click Sargent at one. They've now got another name.
The Marion House?
Marion House, yes. So we did pay. We have a lot of endowment. Whatever has happened here, families are very generous to us and very supportive in terms of fundraising, for us. So we did have money, and we paid for an extra 2 rooms to go on to Marion House, and we paid for a housekeeper, because the number of rooms required, a housekeeper, another housekeeper. And in the group of children who came out the best from the relocation were the teenagers, who got a nice unit of their own and a very, very nice and generous social space. And it was very well decorated. It was paid by the Teenage Cancer Trust. So we contacted the same company and paid from our endowment funds for the rest of the ward to be decorated is the wrong word, but, brought up to the same standard.
Thank you. Now, you anticipate that mainly what we're going to be speaking about is, or rather, our issues with the water and the ventilation systems and the drainage system, indeed. But before we get to that, and I'll try and take this quite quickly if I can, I think we heard in the patient and family evidence, and we see in your statement that there were a number of other issues with the hospital that presented themselves really from the start. And I think in your statement, for example, you remember issues with cladding, issues with windows falling out, and a sewage leak, is that right?
Well, there are often sewage leaks, yes.
Yeah. And I think you agree with the patient and families that there were also issues with temperature and with blinds and TVs not working, is that right?
Yes.
Yeah. I think you indicate in your statement that you are aware of an issue with the smell from the nearby water treatment works or sewage treatment works, depending on your perspective. Is that right?
Well, when you go out, yes. Yes, particularly when you're outside, you can smell it. I don't mean every day, but you can occasionally smell it, yes.
And in your statement, you indicate that you yourself are not aware of the smell having impacted upon patients undergoing chemotherapy in the sense of nauseating them.
Well, maybe that wasn't a very good thing for me to write. I don't know. I mean, I'm not necessarily the person who would be aware of that. The mothers and fathers are much more likely to say that to the nurses as the nurses go in. They would probably, I shouldn't say more important thing, but, there's things they will talk to me about and things they talk to about the nurses that are in and out all the time. And they're much more likely to say to the nurses they felt sick after that smell, but they wouldn't necessarily say that, to me.
Thank you.
They're much more likely to say to me, is everything going okay?
Yeah.
It's a difference in who you are.
Yeah. And I think you were also aware of flooding from showers, is that right?
Yeah.
And I think, was that something that gave rise to a safety concern from your point of view?
I suppose anything like that gives you a concern. I don't know about safety, a concern about the building.
Well, that maybe takes me to the question I was about to ask. A number of the patient and family witnesses indicated that while the main issues that we're concerned with here are around water ventilation and drainage, these other issues might be things that contributed to a loss of confidence in the building. Is that something that you've got any perspective or awareness of?
Well, I do remember the parents, complaining the TVs didn't work. I mean, the cladding was quite a big thing, and mainly because I suppose everybody thinks of Grenfell and cladding, but the cladding was difficult. So much happened. To be honest, I find it difficult to remember the dates and it in great detail. But the cladding we did prophylaxis with the cladding, as I remember, and they had to enter the hospital in a different route. So it did have an impact. And yes, I suppose anything has some effect on your trust, doesn't it?
Well, from your perspective, was that, if we just take, as we start to move through the story in 2015, and we just think about all of these other issues that you've just spoken about, would you say these are things that also impacted upon your, as it were, trust in the building?
Well, I was very aware of them. So much happened that it was very difficult to think what was the main thing that impacted your trust. I suppose, I was much more preoccupied with the infections than I was with anything else.
Yeah. Okay. Well, let's move on then. And I want to start to ask you some questions around events that occurred in 2015, shortly after patient migration. Now, I'll just try and take things in the following way. First of all, try and get an understanding of what I think you've said in your statement and ask you the following questions. As regards you've already made it clear that the doctors were not consulted on what the ventilation system would be. And again, without, I hope, leading you unduly, would you see yourself as somebody who's expert on that question?
No, I would know what the requirements for a transplant unit. I knew you had to protect against, but I'm not a ventilation engineer, and I wouldn't really know how you test water, other than you don't have Legionella in it.
Yeah. In your statement, however, you do indicate what it was that you'd been told in advance that the unit would be provided with in terms of ventilation, and you mentioned something called the JC standards?
The JC, so the Joint Accreditation Committee in Transplant, yes.
Now, I won't ask you to go through any of that in any detail. There's a helpful passage in your statement about that. But are we right to understand from your statement that your understanding of what would be provided was for transplant patients, positive pressured rooms with high efficiency particulate air filtration, is that right?
HEPA filtration, yes.
Yeah. And for patients undergoing chemotherapy in the unit, what was your understanding of what their rooms would be provided with by way of ventilation?
Well, I don't know if I ever knew the detail of it, but we were told that this was a unit which was built to the standards of a hemato-oncology unit.
Can you recall whether it was your understanding that the rooms would have a positive pressure?
I don't recall if we were told that or not.
Thank you. Now, you indicate in your statement that at some point around the move, you sought assurance from the then lead infection control doctor about matters, and he said that it would be safe to start transplanting when you moved in. Is that right?
Yes.
But is it right that shortly after the move there was an issue immediately discovered?
Well, I think the first problem was shortly before the move. We had tried to get data. We'd hoped 6 months after the move we'd reapply for JC reaccreditation. You have to be in a place for 6 months, to do it. And we had tried to get some data to complete our application, which was about air sampling and air safety and things like that. And during that process, it was discovered or noted, I don't quite know the best word for it, that the filters were not in place. So that was the first problem we had, and that, we moved on the 16th and the filters were in place by the 12th.
The 16th of?
Or June. June? Gosh, now you're asking.
And the filters were in place on the 12th of July?
No, they were in place before.
I'm sorry.
We would not have moved without them being in place.
I apologize.
But I think earlier that month, anyway, I can't honestly remember the detail of how it came to light, but the filters weren't. But they were put in place before we moved, and they weren't. And so that may be the response. That email may have been the response from Craig Williams when we'd asked, "Are we ready? Are we safe to move?"
Yeah, you make this clear in your statement. You say that shortly before the move, some sort of inspection or visit was done.
It's a visit,
by colleagues, and they discovered that there were casings in place for the HEPA filtration units, but the units themselves weren't there. Is that right?
But the filters weren't there.
Filters weren't there.
That's my understanding anyway.
Yeah. And what effect would that have had as regards the ability to transplant in those rooms?
Well, we couldn't have transplanted till the filters were put in place. So the effect it would have really had, it would have delayed the migration of the hospital.
Can you remember what your reaction was or how you felt at the time about this?
Very surprised.
Yeah. I wonder if we might just look at some of the email correspondence from around this time. And I wonder, Mrs. Soshka, please, could we have in front of us a document at Bundle 8, page 125? Now, if we can just maybe focus upon the email that's set out in blue script from Professor Gibson. Are you able to read that, Professor Gibson?
Oh, yes.
Yeah. And you say, it's an email from you to a colleague, I think. We have a planned transplant who will need HEPA filtration around the 20th of June. If we can't guarantee this, then we need to refer to Newcastle. That will cost £250,000. It is inconceivable that a transplant unit was built without HEPA filtration. Truly shows the priorities, all show and no substance. You may think that the email speaks for itself, but I wonder if you perhaps could tell us a little bit more about what lay behind that and the frustration that you expressed.
Well, I think the frustration reads for itself. You did say, what lessons do we learn? My main lesson, I'm never about sending another email. But I think we were pretty shocked that it is such a basic requirement that the filters were not in place. It isn't easy to send out a patient. The cost is irrelevant, actually. It's the planning that's the problem. It's not the cost. And there was so much good publicity around this hospital. It was a flagship hospital and all the rest, and it just was I was just very angry that the filters weren't in place.
But I'm thinking about the statement that you make at the end of the email about truly showing the priorities, all showing no substance. Can you say whether that reflected any broader concern that you had?
Not at that time, no.
Now, we know from, or we've seen evidence from one of your colleagues, Dr. Ewens, who tells us in her evidence that around this time, the unit was anticipating carrying out a transplant in a particularly anxious case, and that around that time, a further issue arose with the discovery of, I think, what she describes as high particle counts in the corridor and in the rooms, the bone transplant rooms. Is that something that you've got a recollection of?
Yeah, but that would have been after the move. Yeah. That would be my recollection, that they were air sampling after the filters were in. I mean, the filters were in, and we were reassured that they were validated and all was well before we went. But yes, and we did. I think my recollection is it was very difficult to, or the control of infection at that time thought it was very difficult to interpret that because the doors have all got to be closed. You know, the particles were in the corridor, and this is all about having the right level of positive pressure to allow the air to go from the corridor into the rooms, and it made it difficult to interpret. But we had, I do understand why, that statement about trying to get transplants done, because we'd been very keen not to move any really sick child. So we had tried to plan things so that we we hoped there wouldn't be anybody that would need to be moved by intensive care or anything. So we were needing to start transplanting.
Yeah. There are a number of emails over this period and other documents. I don't want to look at too many of them. And we've also got your evidence and that of Dr. Ewens. But are we right in understanding that these concerns continued over July and August and indeed into September?
Yes, I think you're right. There are a number of emails. I was copied into some and not all. So, but I think I've probably seen them all now. The first 2 transplants went ahead. There was kind of no problem. But then I don't know why there was some air sampling done. There was some evidence that we've already said that the air particles were high. There was evidence that that there had not been sealing of light fittings and such things. So there was air able to enter these cubicles via non-sealed light fittings and that we then, they were sealed, or a number of the rooms were sealed, the air sampling was repeated, and there was concern, particularly by this time Therese Inkster was the control of infection lead, and she was unhappy for transplantation to go ahead. And I can't remember the dates, but August or September seems about right, because there was aspergillus and high particles found in air sampling on plates.
Thank you. And again, I wonder if you could just give us an impression of the level of concern and frustration within the unit around these matters at that time.
Well, I think we expected that the transplant cubicles would be built to a standard and that we wouldn't be seeing these kind of problems. I mean, the frustration is that, as I've tried to explain, you have to plan a transplant. You can write a stroppy email that says if you don't sort this out, it's going to cost you £250,000. But that isn't the reality, because even if you want to send them somewhere, and it would be Newcastle for us, they've already planned all their transplants, and they may have many months before they can accommodate another patient. Yeah. So sending them out isn't the solution. It may seem.
Yeah. Well, I wonder if we might just look at a further email that might just illustrate your concern around that. Now, we're going to skip one of the emails that was on the list that I gave Mrs. Shoska. If we go to an email which is at B8129, page 129. It's an email of the 19th of August. 2015. And there's obviously been some redaction here, Professor, in order to deal with patient confidentiality concerns. But are we right in understanding that this indicates really what you're saying, that there was a concern about the ability to push on with a transplant in relation to patients, and that impacts on you, but also on the family, I assume?
Yes, it impacts a lot more on the family, than it does on me. They're anxious it's a very scary time at the best of times, and having postponements is hard. And there's the fear of losing the donors, there's the fear of a lot of things.
Yeah. I wonder if we might move to page 132 of this bundle, please. So again, are you able to read that, Professor? Thank you. We now need a definite decision regarding SCT transplant rooms. I understand that if we couldn't go ahead 2 weeks after the last meeting, that we would send children elsewhere. 2 weeks have elapsed. So you either reassure the SCT team that these rooms are fit for purpose now, or we make arrangements for these children to be treated elsewhere. We would not have moved until it was known that the environment was safe.
That's true.
Again, you may say that just speaks for itself, but would it be fair to say there's a fair amount of concern building by this stage? I think
that there was a lot of concern. We had a control of infection lead who said the rooms were not suitable to transplant in. We have to take our instruction from control of infection. There was a lot of argument, maybe argument. There was a difference of opinions on whether they were suitable, or not, and risk was being assessed. Now, and control of infection had a very clear view. She was not going to say that these rooms were suitable. We then had to, but the other side of the coin, you have a child who needs to go to transplant. You're never moving them to Newcastle in the time that that happens, and a risk assessment was being taken by, I think, our medical director at that time. Should we proceed or not proceed? I feel quite strongly that was a very difficult position for the transplanters to be put into. I do feel that we had the right to expect to be transplanting patients in rooms that met the specifications.
And I wonder, against the background of what you've just said, if we could look please at page 133. Again, if we can just enlarge it slightly so we can all read it. I wonder, Professor, if you just want to take a moment to read that email from you and indicate to me once you've done that.
Well, I think it just highlights our frustration that the rooms that were not suitable and that any remedial work had not resolved the issue. It hadn't happened on time. To us, it was very urgent, and I think we felt that perhaps there wasn't the same urgency being shown.
Who is Jennifer Armstrong?
She's the medical director, so she is at board level. So she is the most senior of the medical directors.
So she's management? She's
management, yes.
And when you say, as a clinical team, we have lost faith, what did you mean by that?
Well, we'd initially gone over, and we hadn't had any filters at all. We now had particle counts and aspergillus in the air, and the rooms weren't sealed. We just felt we were going from one thing, to the next. And where was the resolution that would allow us to safely resume transplantation?
And you say, we feel that we are due an explanation. Did you get one?
Well, it's an angry email. I totally accept that. But she did attend a meeting 3 days later.
And what was the explanation?
Well, I don't think there was an explanation, but she did give instruction that things were to move forward.
And at the end of the email, you say that the transplant programme has been severely compromised. And was that your assessment of things at that point?
Well, we were postponing we were continuously postponing. And that does compromise your programme. You postpone one child, it ricochets.
Does it take us back to what you said earlier about the narrow window and the
Yes.
anxious decisions to be made?
Yes. Well, there are some you can delay with comfort, but not all of them. And I can maybe delay them with comfort because I know there won't come to any harm from the delay. That's quite different from a parent's perspective.
We can put that to one side. Thank you very much. There's just two further matters I wanted to ask you about as regards this stage. One that you've already touched on, and I just wanted to be clear I understood your evidence. You said that there was going to be a JC inspection, and you say this in your statement, about 6 months after the unit moved. And there was some difficulty about the provision of information that did not permit that to go ahead. Have I got that correct?
There was difficulty about information. I suspect the technical team were just so busy trying to get the hospital open, but we couldn't go ahead because 6 months late, well, not 6 months, because of all the problems we had with the environment. Yes. And we were moved to, eventually, as you know, we moved to transplant in the adult unit, and we weren't asking for accreditation to transplant in that unit. We had to wait till we came back to 2A or to Schehallien in 2022. Before we could go ahead with our JC application, which I have to say has happened and was successful.
Thank you. The second thing I wanted to ask you about is we understand from information available that there was, while all of this was going on in the paediatric unit, there was an issue with the adult bone marrow transplant unit on Ward 4B. Can you recall whether that was something that you were aware of at the time?
I was peripherally aware of it. I didn't know the detail. You know, I was probably the most reluctant person to move off the York Earl site because I felt I was leaving behind something I built. But the one good thing was we would be co-located with our adult transplant unit. And you have to remember, we're paediatrics, they're adults, but there is teenagers and transition in between. So we saw lots of advantages to being co-located with the adult transplant unit. So it was very disappointing when they came over and then went back to the Beatson. We heard all the rumours, but it was only rumour. I think the detail I've probably read for this inquiry, more than I knew at the time.
And if it's possible to confine yourself to what you knew at the time then, even if it was only rumours, what was the nature of the concern that led to the move back?
That the environment wasn't appropriate for transplanting.
And in what respect? The water, the ventilation of what?
Well, I heard the ventilation.
So if we just draw 2015 to a close then, I'm going to ask you to just think about, if you're able to, what your reflections on all of this were at the time, or indeed even now looking back. Thinking about the responsibilities that you explained to us earlier about the provision of care and the provision of a building in which to provide that care. Did you have any concerns over the period of 2015 that the board might not have provided a safe environment for the provision of care?
I don't think in the way you're asking, no. When we came over, we expected snagging problems and minor problems. In fact, whatever the tone of emails are, and I'm quite famous for my emails, we accepted that there would be snagging problems. The filters were quickly sorted. There was a lot of email exchange, a lot of meetings, and they were put in place, and in a timely enough manner that migration went ahead at the right time. So I think that everything was done to remediate that situation. We did expect some problems with the cubicles. And I think we thought once they were sealed, and it wasn't just that they were sealed, there were plans being made in 2015 for the builder to upgrade some of the cubicles, perhaps 2 at a time, to higher specifications. So I think we felt that although, yes, there were problems, they were being addressed. And once they were addressed, it would be okay.
Yeah. But in the meantime, I think, as you've indicated, you felt that doctors were being put into a difficult position and having to strike a balance of risk. Would that be fair?
Well, to a degree, yes. Yes. But, we didn't have ever to make the decisions on our own. We did have a medical director. We did have Jamie Redfern, who was very supportive. I think they were very, but if you read the emails, which I've had to do, Alan Mather's email to Teresa Inkster, or I can't remember who it was to, does say that he's in favour of proceeding, but he'd only do it if control of infection and the transplant team agreed.
I think in her statement, Dr. Ewens describes this period as being one was extremely stressful for these reasons. Does that capture it as neatly as it can be captured?
Yes, it wasn't what we expected, but I still think the efforts were made to resolve it. And I thought that was going to be the end of the matter. I didn't think that problems would, yes. Postponing is very difficult because you have to deal with the families, you have to worry, will you lose your donor? And it isn't something that you can turn around, quickly.
Thank you. Now, we're getting close to the point at which Lord Brodie indicated we might take a break, but I think there's one further matter I might just be able to squeeze in before we do that. And I'm going to move forward in the chronology to 2016 and 2017. And I'm going to ask you some questions about that. Now, I want to say something just at the outset of all of this questioning. My desire throughout this questioning would be to avoid any discussion of any individual patient case. The inquiry has not been set up to decide what happened in individual patient cases. So please do not think that's what I'm asking you to do. But again, you've set this out in your statement, so if you'll forgive me, I will just lead you a bit on this. Is it fair to say that colleagues in 2016 and 27, by that I mean clinical colleagues, saw an increase in unusual infections in the unit? Is that right?
Yes, I think, we would say, we would get reports back from infections that we weren't, I think I said in my statement, were they unusual or were they renamed or, we weren't quite sure, but we were beginning to become suspicious. We were seeing a pattern. Yeah. But I stress, and I think they would all stress, that it is for us to say to microbiology, is this normal? It is for control of infection to say if it is or not. Yeah.
I think just to mention, going back to the classifications, I think the papers we have, the IMTs, for example, indicate a concern around Aspergillus in round about August 2016. Is Aspergillus is a fungus?
Fungus.
Yeah. And I think, again, not going into any individual cases, in 2017, again, the IMTs and the other documentation indicate something happening in relation to gram-negative infections. Would that be right?
Yes.
Was it? I think you do deal with this in your statement. Are we right in understanding that you didn't think over that period that there was an environmental explanation for these things?
We didn't. You give children lots of steroids and you always see, fungus. I think you did ask, did we think 2 cases was... I think that the problem, you react to fungus very badly because it does need a lot of treatment and you've often to stop treatment for a long time. And I think it's probably the seriousness of it, rather than the numbers. Yeah. That I can say that I did note in the IMTs that there was the suggestion that Edinburgh was seeing the same problem and it was related to the clinical trial. I've checked with the chief investigator. There was absolutely no rise in the incidence of Candida, during that time period. And that's not my recollection either. Yeah. We just had some not very nice cases.
Did you say Candida?
Well, one of the years that the concern was around Candida.
Yeah. Is that also a fungal infection?
It's a fungus, but it's kind of an endogenous fungus. We all carry Candida. You suppress your immune system and it comes to light. Yeah, Aspergillus comes from the atmosphere.
And what I'll maybe just sort of conclude this section with really 2 questions. The first one is, you've already answered the question that an environmental cause was not suspected from your point of view at that time. Why was that?
I don't know that I can answer that question. I think we just, I don't know is the answer to that. It certainly wasn't raised by control of infection, at that time. We would have taken our concerns. We do meet the microbiologists every day. At that time, it was probably face-to-face. Now it's on Teams or by phone. We would have raised our concerns, and they didn't express any concern that this was environmental up until March of 2018.
Yeah, I think in your statement you do deal with this and you say the microbiologists didn't advise
No.
it was environment. So that was one aspect. Another aspect that we're aware of from other witness statements is, are we right in understanding that there was line care work
A
going
lot
on?
of CLABSI work going on, yes.
CLABSI work.
It's the central line.
Yeah.
It's just how you care for a central line.
Can you say whether that indicates at least a possible hypothesis that people maybe wondered whether what was going on with infection was to do with line care?
It was looked at, it was audited, and the audits were very good. When you say to do with line care, most of these the infections occurred in somebody with a line.
Yeah. I meant line care rather than an environmental cause.
I think the nurses are audited. Nurses do the line care, they are audited regularly. I think they work to extremely high standards. There's always improvements, as new things come out, and I don't think there was ever any suggestion that the nurses. I personally don't think there was any reason to think that the nurses were handling these lines in any way that was not of best practice.
Thank you. And the final aspect on this question of whether or not or why people perhaps were not thinking that there was an environmental cause is something that appears in the statement of Dr. Ewan's. She says that she felt there was no clustering going on in relation to these infections. Can you say whether that's something that you recall?
Yes, if this was coming, from one source in the environment, you might expect a number of patients to have the same infection that could be typed, and they would be identical. And that wasn't what happened. Yeah. The typing didn't link the organisms between patients, and neither did they link it to environmental, organisms taken. But I think she sort of means that if there were 3 Pseudomonases, you could have typed those Pseudomonases and they'd have all been exactly the same type.
I think what she was really meaning was just in her statement was the appearance, whether they all appeared at a similar time and place, that kind of idea. She was indicating that she doesn't recall that being what was happening and thus doesn't see that as being something that would have pointed towards an environmental explanation.
Well, I don't know what time period she's talking of.
I think she's talking about 2016, 2017.
Yes, you would be right.
Yeah.
Yes.
And the final thing I was going to ask you then about this period is just before we move into 2018, can you remember whether at any point in towards the end of 2017 you were aware of any concerns about the environment raised by microbiologists, whether through the whistleblowing process or whether through any other process?
I think I was aware there was an undercurrent concern from the microbiologists about the environment, but I didn't know about it in detail.
Okay, thank you. Lord, I wonder if this is a useful moment.
Yes, we'll take a break for coffee, and you will have I hope you will have the opportunity to have a cup of coffee, Professor, and we'll try and sit again at 5 to 12.
Please stand.
Mr. Duncan.
Thank you, my lord. Professor, I'm going to move now into 2018 and we'll walk through the chronology of the various events that begin around then. In order to do that, I'm going to ask you to give us a little bit of context around certain procedural things in order that we understand how things work. So, for example, and one of the things that you discuss in your statement is how clinicians and colleagues share information. And for example, you refer to regular multidisciplinary meetings. I think probably what I'd be quite interested to hear you tell us, if you can, is give an overview of how information is shared among colleagues about issues of concern or importance affecting the ward.
Okay, I'll try. So we have twice a day, we have what we call a handover meeting. So everything is, of course, now done by Teams. It would have previously been face-to-face during some of this, pre-COVID. But so in the morning, the medical staff, the middle grade medical staff, what you'd call registrars and that level, and the consultants who want to be there and whoever's on service for the different areas will be there, and the nurse who's in charge of the ward. And they will go over any of the unwell patients, what we'd call a watcher. You know, anybody who had been particularly unwell overnight, so that might be somebody, and they would tell us any new temperatures, or they would not necessarily, other than a Monday where we'd go over everybody from the weekend, they will highlight the patients that there was something specific to tell us about. So that might be a temperature, that might be somebody going to theatre for a bone marrow or lumbar puncture, but they will highlight the issues on the ward. After we've done the ward rounds, we will contact microbiology if we have any queries with them, and we'll have a lunchtime handover at 12:30, when we will then go through every patient on the ward. And again, we will then update on what needs to happen. Do the antibiotics need to be changed? Do they need blood? Do they need platelets? Or what should be happening to all the patients? So that is the two kind of ward-wide general, meetings we have to update. As individual disciplines, and by that I mean by leukemia and solid tumours, we will each have a number of weekly meetings where all patients will be discussed within a multidisciplinary team. So we will discuss on a Wednesday afternoon, we'll order all the chemotherapy for the leukemia patients. The nurses from the ward will be there, the nurses from daycare will be there, pharmacy will be there, and we'll discuss any issues we've got there. And there's a similar meeting that will occur for solid tumours. In terms of other meetings that I suppose are relevant, we have what we call a Schahalian unit meeting, which I chair, and we have that every second month. We will go through any issues that we have on the ward that concern us. That will include everything. Somebody from control of infection comes and they'll highlight any problems that we've got on the ward. We will talk about any issues related to staffing, education. We have an agenda that we will work our way through, and that's a multidisciplinary meeting. So the doctors will be there, the nurses will be there, the pharmacists, the social workers, the outreach nurses, psychologists, anybody who's got any input into what is a multidisciplinary team. The in-between months, we have a clinical governance meeting, which up until recently, J.M. Sastry chaired, and that will go through a slightly different agenda. It will go through any DATEXs. So DATEX is the system that we use to report. It's an electronic system that we will report, any incidences, if there's been any delays in chemotherapy or any problems with it or anything, like that. And so we'll have a governance meeting and we'll have a unit meeting, which is attended by a multidisciplinary team. But we are a relatively small, so we also have a consultants meeting on a Monday afternoon. And, if we had any real concerns, that would be raised at that. So we have a lot of meetings we can raise issues at.
And share information.
And share information, yes.
And with one exception, I think what you've described there is really a process of sharing information through discussion. The exception, I think, as you mentioned, also the use of something called the DATEX system. And that leads me to my further question is, to what extent, if you're able to answer this, is the process that you've just described of these oral exchanges of information, to what extent are you given regular updates about issues of importance that are arising in writing, you know, whether in email or in other systems or other forms of alert?
I'm not quite clear what you mean by that.
Well, so if, for example, there was an issue of importance on the ward, say, for example, there was an issue arose in relation to an infection pattern, presumably that would be something that would be discussed among you at the meetings you've just described.
Yes, on a Friday afternoon, or Friday lunchtime, our handover is more extensive. So microbiology comes to that. Well, that would be our opportunity to discuss anything. You know, we would discuss on a daily basis any individual infections, but if we were concerned about any patterns, we can bring that up at that time. We also have a sort of record where we record any gram-negative infections, any lines removed, that type of thing, and we go over that on a Friday.
Again, I'm taking us into territory which really are for further hearings, but it's helpful to hear your perspective on them. Are you indicating to us that, in addition to the oral exchange of information about things to do with infection, there are systems, IT systems, which would enable you to be able to see whether there was an issue at a particular time?
No, we wouldn't record infections necessarily on a Datex, no.
Are you aware of any other?
But we would hear about them at the handover twice a day, so we'd be very aware of them. And that's, you know, if we had concerns, then we would contact microbiology first, and then their contact is to control of infection. But you have to remember, these infections are identified in the lab long before they come to us. So, you know, the system of communication is not necessarily us to them, but them to us.
Now, the next thing I'm going to ask you about, which follows from what you've just said, I think I take you to be describing the usual way that things work. Where something of particular concern arises, are we to understand that there are further processes that can be engaged, one of them being something called a problem assessment group?
Yes.
Can you tell us what that is?
Well, the problem assessment group, as I understand it, it's really a control of infection that run those. And that would be when if there was a concern with any one infection identified, if there was two within, I think it's a 2-week period, then there's an IMT called.
And what's an IMT?
I knew you were going to ask me that. I can't remember.
Well, if I might be...
The management team, something management.
Is it an incident management team?
Yes, it is, yes.
And again, maybe implicit in what you've just said, would that again be something for infection control?
Yes.
And again, implicit in what you've just said is, I'm not going to ask you to give us an enormous amount of detail on how these things work. It's just to allow us to understand what they are when we start to look at the minutes of their meetings. But if you could very briefly just tell us what their purpose is.
Well, their purpose is really to decide or try to come to an agreement, if not decide, where the source of the infection came from. And is it enough to cause any concern? So whatever the infection is, one of the clinicians will give some history on, you know, for example, there are some infections that can be both either endogenous or exogenous. You know, there are some that you can get in the environment, but you can equally get them from your own gut so you'll give the kind of details. Did they have any diarrhea? Did they have any mucositis? Was there anything else to suggest this could have been of exogenous origin rather than anything else? And that will be discussed. There will be some kind of timeline of what rooms the patients were in, you know, where they travelled around the hospital to see if there's been anything similar. And then as a group, as a IMT, or a PAG, they will come to a decision, was this just an endogenous infection that gives no cause for concern, or was it something endogenous that might give some cause for concern?
And is it obvious from looking at the minutes that these are multidisciplinary meetings?
The PAG will...
I'm thinking more about the IMT here.
The IMT will depends what you call multidisciplinary. There will be clinicians at it. There will be a nurse representative from the ward. There will be a nurse representative from daycare, because most of our patients spend some time both on the ward and on daycare. Then there will be control of infection at it. There will be estates. There will be facilities. So it is multidisciplinary in that it takes the group of people who would need to bring around any rectification if that had to happen.
Thank you. And the final contextual matter I want to ask you about is something we touched on earlier. What is an SBAR? SBAR?
Well, it is something where you put down the what the problem is, and then you work your way through what can be done about it.
Yeah, it's a system of reporting and assessing and proposing action in relation to an issue. Is that right?
Yes.
And did I take you to say earlier in your evidence that you were aware of concerns that had been raised by some of the microbiologists in late 2017? I can't recall whether you said you were aware of any SBAR that they had prepared at that time about.
I wasn't aware of the SBAR. I mean, I have since read, the SBAR as part of the documentation sent for the inquiry, but I wasn't aware of it. But I was aware they had concerns, and that they had expressed these concerns to the board. Well, let me cut to the chase here. Do you think that is the sort of information that you ought to have been made aware of at the time? Well, I would say from the microbiologist and control of infection point of view, I think they felt they were raising it with the appropriate people. We were discussing individual infections, with them, but, they were not looking for action from the clinicians. They were looking for action from senior management. Yeah, thank you. Now, if we move then into the events of beginning in March 2018. And as you've indicated, we've asked you to do a little bit of reading in advance of this. And the purpose for that is to try and see if we can go through this reasonably swiftly. Have you had an opportunity to refresh your memory in relation to at least in relation to some of the IMT minutes from the period beginning in March 2018? Until June 20. Well, if we just stay with March at the minute. Yes, I have read them. Thank you. Would you be able to just, even at quite a high level, summarise your recollection of what happened in March, or would you prefer that I put to you what we take from the IMT minutes? Well, I'll try. There is quite a lot of detail in them, and I think you have to also be very aware that these IMTs occurred very frequently. Sometimes they were occurring daily, sometimes they were occurring every second day, and some of them were quite repetitive. I have to say, as I read them, I can't remember the detail of them all, but I think, I don't mean this to sound critical about the taker of the minutes, but I'm quite sure some of the things are perhaps not represented exactly as they might have been said. Yeah. So I think you have to say. So my recollection is that I think around February sometime, Teresa Inkster, as the control of infection, came to visit us as a group of consultants to say that they had there had been a positive blood culture in a patient for a very unusual organism called Cuprivadis. I have to say I'd never met anybody with it before. So it was very, very rare. There had been a previous one, I think in 2016, associated with aseptic pharmacy unit, where the typing had showed a connection between the source and the patient. And to interrupt, sorry, the source being? I think water. Yeah. Within the aseptic unit. And then there'd been another case in 2017. So this was the second case. So this is a very rare organism, and I think 2 cases occurring within roughly 6 months of each other caused her a great deal of concern as an experienced microbiologist. She then met with us and told us that they had been sampling the water outlets on the ward where, gosh, I've forgotten what they grew, but they certainly grew cuprovatus, and they grew other gram-negatives, and I think one of them was positive for Pseudomonas, or, other environmental organisms.
If I jump in at this point, and were there also fungal pathogens?
There were later, but the fungus takes a bit of time to grow, so that wasn't available to us at that time.
Okay, sorry, please continue.
So we had a number of, I think there was a number of IMTs looking at this, where she reported back the findings of investigations within the water supply, where gram-negatives were grown from the water, cuprovatus was grown, and I can't remember, to be honest, the details of exactly all the organisms. There was a lot of talk about the hypothesis, and what we could do about it. There was talks of, if I remember rightly, and so much did happen, and I'm not sure I do remember the exact course of events, but, I remember IMTs where we looked at taps, which were very sort of complex with lots of bits that bugs could sit in and form biofilms. There was lots of talk about straighteners being in the taps, which was a completely new concept to me, which could also encourage the growth of biofilms. And at the outcome of that series of IMTs, as I understand it, was that because they were growing from so many sites, that they would stop sampling, they would treat the water with silver hydroxide, and they would remove the taps, clean the taps up, and put filters on the taps.
Thank you. So I take from what you've said, and perhaps just filling in one or two details that I take from the IMTs is, first of all, there was a concern that there was an increase and clustering of gram-negative infections, beginning with the cuprovatus one.
Yes, and that they were environmental.
Yeah, and I think you mentioned, I think the IMTs indicate cuprovatus, Stenotrophomonas,
and Pseudomonas,
yes. And possibly later fungal pathogens as well. And I think the IMTs indicate that those were being found not just in the Children's Hospital, but in the broader hospital, or is that not something you can...
Well, I can't remember the exact chronology, but at one stage they sampled PICU, intensive care unit, and they sampled the renal unit, where, hemodialysis is ongoing, so the water supply is also very important. And I can't remember exactly what they isolated from each, but they did get infections both in the renal unit and in PICU.
Yeah.
Which implied that this was not just a 2A or a Schehalian problem, and that sort of altered the hypothesis, because the initial hypothesis had been that there might be a infected outlet and patients or staff were spreading it, with their hands, but the fact that it was now found in other areas, of the hospital, certainly patients and the doctors and nurses couldn't be held responsible for spreading it to those areas. And I think once that was found, they then sampled, I think it was 4B or 4C, I can't remember, but it was the haematology and the transplant units in the adult hospital.
Thank you. And I think another thing that we heard a lot of evidence from the patients and the families, and again is referred to extensively in the IMTs, is that really from the very start of the discovery of these issues, there were measures taken to protect patients from the perceived risk, restrictions in the use of water. You've already mentioned dosing of the water. I think there was mobile hand wash units. And then ultimately, are we right in understanding that the IMT effectively closed at the end of March or so, at the point that filters had been put onto the taps? Is that broadly your recollection?
That's broadly, yes, that is. There was a period of time when the dosing and when there was, before the filters went on, when there was concern about the safety of the water and concern about the time of the dosing where the water had to be turned off or they couldn't use it. So there was periods of time when families couldn't shower or couldn't wash, and I don't know what's worse, cleaning a baby with a a wipe or a 15-year-old, but it was not easy for families, to do that. We had bottled water for hand washing and cleaning teeth and sterile water for drinking. So there was a lot of measures put in place during the dosing and until the filters were put onto the taps. Yes, and then once the filters were on the taps, there was no bugs found post-filter, it was thought that there had been control measures put into place and the IMT stood down.
Thank you. What I would like to do, having established that chronology with you, is just look at 3 or 4 bits of it just to understand your recollection of particular aspects of that. And I'm going to start towards the beginning of it on the 6th of March, an IMT that took place on that occasion. And what I was going to ask you to do, Professor, is to have a look at your statement, which I wonder if we could have put up on screen, Mrs. Soshka. And so it would be at page 46, I think, of the statement. And it's paragraphs 183 and 184. So if we can enlarge those. And if we just, you want to just take a minute to read through those and tell me when you've done that?
Well, if I go through it bit by bit, I think the first paragraph is that I attended that IMT at the beginning of March along with my colleague Dermot Murphy. And when we looked at the organisms that had been isolated, they were mainly environmental, and that was the cause for concern. And I think I'm sure that either there was fungus, I think, grown. And at the time of that IMT, we didn't know which fungus it was, but we were concerned that the combination of fungus and environmental organisms did suggest that there was something fundamentally wrong with the infrastructure. I don't know what I said after that. I think you've asked me. I was not aware that Teresa Inkster and her colleague, I have now read their SBAR, had written to management 2 years earlier. I wasn't aware of that. I've since read that SBAR. I think you asked, was it the clinician's responsibility to escalate this to management? The normal practice would be that in an IMT like this, senior management would be present and would escalate up the ladder to the chief executive via senior management. The only reason that we did something to escalate it was that Teresa Inkster had told us that she'd had no reply to her SBAR. And, this was a very serious matter for us. And we were those closest to the patients. And we wanted to be sure that this was escalated up in a way that it was acknowledged at the highest level, those who could take some action.
Thank you. Now, I've been asked to have you confirm or clarify one aspect of this. At the very end of paragraph 184, you say Teresa Inkster had stated at the IMT on the 6th of March that she had highlighted concerns about environmental issues to GGC and Health Protection Scotland via an SBAR 2 years earlier, but had no response. Now, can you say whether you have a recollection of her, well, let me take this in stages. Are you indicating there that you took her to be saying that she had no response either from GGC or from Health Protection Scotland?
I can't remember about Health Protection Scotland. I certainly understood her to say from GGC.
Yeah. Thank you. And I wonder if we could have a look, please, at the minute of this meeting itself, just to perhaps assist you. Mrs. Soshka, it's bundle 1. It's page 56. Now, just so you can orientate yourself, Professor, just at the top, we see Incident Management Team of Tuesday, the 6th of March, 2018. You see that?
Yes.
And you're there, Dr. Inkster's there, and your colleague, Dr. Murphy. Yeah?
Yes.
Now, Mrs. Soska, could you take us, please, to page 157? I think it was just the next. So I do apologise. It's my mistake. Page 57. Thank you. Thank you for responding to that so quickly. Could I ask you, please, Mrs. Soska, to enlarge the section underneath microbiological report? And could I ask you, please, Professor Gibson, to just look at the second bullet point?
Yes.
TI informed the group of the findings from the microbiological sampling carried out in the tap and shower head. To date, cuparvidis and some others are mentioned. And then it says cuparvidis is going from the hot tap and the flow straightener. Is that right?
Yes.
And I mean, I take your point about the accuracy of minutes of meetings, but is it your broad recollection that there certainly was discussion of flow straighteners at?
Well, there definitely was discussion of flow straighteners, yes.
And the other bit I just wanted you to have a look at, please, you drop down to a bullet point that is the second from bottom. I do apologise, the bottom one. Have we enlarged that one, Mrs. Soska, the one that begins BG and DM queried? And that, I think, is the bit that connects to paragraphs 183 and 84 in your statement. So if you just want to take a moment to read that paragraph and then confirm to me once you've done that.
Yes, I've read it.
Thank you. And if we just take the first section, BG and DM queried if the concerns of the clinical teams relating to the environmental risks and to had been communicated higher, TI explained that she shares these concerns and had indeed reported these to the highest level in GGC and HPS over 2 years ago. DM and BG felt dissatisfied that there had been any response from senior management or out with GGC, which offered reassurance to clinicians. Now, if we just pause there. Now, again, I take on board your caveat about minutes, but...
no, I think they're accurate.
They're accurate.
Yes.
And just thinking about the clarification that I was asked to seek from you, does that suggest to you whether or not the absence of response was only from GGC or was also from out with GGC?
It suggests to me it was also from out with GGC.
Thank you. We can put
But
that.
it doesn't say who out with GGC.
Yeah. I mean, it may speak for itself, but what was the concern that you and Dr. Murphy had at this point about this aspect?
Well, I think these were environmental organisms. You know, if I'm honest, I'm not sure we ever, prior to this, had really thought of whether organisms were environmental or not. We thought of them as endogenous and exogenous, if I'm really honest. But as clinicians, we knew that whether you call them endogenous or environmental organisms, we were talking about Pseudomonas and Stenotrophomonas were organisms that we feared in our patients. You know, they were organisms that formed, certainly Stenotrophomonas, that formed biofilms that could be very difficult to eradicate. They were often resistant, or sometimes, I shouldn't say resistant to antibiotics, But, stenotrophomonas we would often treat with Septrin, which we don't like giving to children because it drops their neutrophil count. So, it was complicated for that reason. But I think our concern was that these organisms, forget about Cupra vadis, because I'm not sure we knew anything about it prior to this, but the stenotrophomonas and the Pseudomonas were the kind of organisms we would fear in children and the kind of organisms that could be life-threatening to immunocompromised children.
In a later IMT, and I won't take you there, you recorded as describing organisms of the sort you've just described as lethal. Is that essentially what they are?
Lethal, fatal, choose your word.
But for your patient cohort, I mean...
They can be,
Yeah.
yes.
Yeah.
You hope that you treat them, you remove the line, and they're not. And I think I've already said that for children in RHC, Glasgow, treated up front for ALL, in 10 years we didn't have a single infection-related death. I exclude the transplants, but of the non-transplanted patients, and we did see these organisms. But, it's not like having a coagulate negative staph that's unlikely to make anybody really sick. Yeah. These are the organisms that make you really sick.
Yeah, thank you. Now, I want to then just move on a little in this bundle, please, to page 60. And I think you've got in front of you there, Professor, another IMT dated the 9th of March 2018, is that right?
Yes.
And again, you're recorded as being there. And on this occasion, I just want you to look at the section, it's underneath investigations, it's the second last paragraph on the page. The Dr. Inkster informed the group that an S-bar from 2014, have you got that?
Yes.
I wonder again if you could just take a moment to read that and tell me once you've done it.
Well, I think it's accurate as what was said at the IMT, as I remember. She talks about an S-bar in 2014, which advised against installing flow straighteners in taps in high-risk areas. And I think by high-risk areas, she means in areas where immune-compromised patients are being cared for. And my understanding is that flow straighteners encourage the growth of a biofilm, and that if you encourage the growth of a biofilm, then you're going to encourage infection. And, that's where the bugs will seed out and be difficult to eradicate from there.
And do you call a discussion along the lines of the board having felt that the cost implications of changing the taps were impractical?
That was said at the IMT. I remember that being said at the IMT, but I wouldn't have known about it in 2014.
Did you then, or do you now, have any reaction to that?
Well, yeah. If there is a guideline which says, or a building recommendation or whatever you would call, whatever guideline you give about straighteners going into taps, then I think it should have been followed.
Now,
I have to say, this is not something I would have known had this not, I don't know, I mean, I wouldn't have known if you put flow straighteners into taps or what's in a tap. I learned of these things at the IMT, so I don't have any expertise in them at all.
No, we have your evidence on that, and nobody is expecting you to give expert evidence on the safety of taps or ventilation systems or anything of that nature. We can put that to one side, Mrs. Soska. And I wonder if we could go back to your statement, please. It's at paragraph 260 of the statement. If you just bear with me, I've not noted the page number, so please just bear with me. Oh, you're ahead of me. Page 63. Paragraph 260. Again, could you just take a moment to read that, and then we can discuss what's in it.
Okay, I've read it.
Thank you. Now, helpfully, you've quoted from the IMT minute there, so we don't need to open it. But I wonder, again, you may feel that that speaks for itself, but could you maybe just explain to us what your concern was around the use of the language around prophylaxis being given, quotes, just as a precaution due to issues with the water supply, close quotes?
Well, it depends how you interpret the word precaution, doesn't it? I mean, I think we were saying that we were making a recommendation, here, and I'm not sure that precaution really and recommendation are quite the same word or have the same impact.
Yeah. Does this go to really the question of what you would be saying to patients in relation to the provision of this medication?
I mean, it's very likely, though I can't remember with detail, that there was there would have been a written statement that we'd have given to families. But I can't remember if this happened here or not. But it's what we would have done is that we'd have each taken responsibility for our own patients probably and gone round and discussed prophylaxis with them.
Yeah. I mean, you say in your statement, I felt it wasn't the best word to use in the situation because we had serious concerns about the risk of infection. And to be clear, I'm only going to ask you what your recollection is. I have nothing else to put to you on this. Am I taking you to indicate that you saw the provision of prophylaxis as being around the risk of infection? And is that therefore something that you would have wanted to communicate when you were speaking to your patients?
Well, we were giving the prophylaxis because of the risk of infection.
Yeah. And I'm just trying to tease out what it is you're getting at in this paragraph. Are you indicating that to describe it as just a precaution to do with issues with the water supplies, maybe just saying a little less than should be said?
Perhaps, yes.
Yeah. Thank you. Now, just to complete the chronology around this stage, you've already confirmed to us that the IMT process closed around the end of March. At this point, in this period of time, was there also a discussion around a look back on the infection patterns that there had been in the last 2 years?
Well, there was discussion around that, but I can't exactly remember when that happened.
Yeah.
It might have happened later on, to be honest.
It really goes back.
I can't remember.
There is a discussion of it in the IMTs, and would you be content that we just proceed on the basis of that? It may not matter particularly when it happens.
Yes.
Thank you.
Yeah.
But it's really just to connect to what you said earlier, that in 2016 and 2017, the advice coming to you was not that there was a suspected connection to the environment. Is that right?
Yes, that's right.
But at some point in 2018, it was decided to have a look back at that. Is that really all it comes to?
Well, it's in 2000 and from February, March 2018, we were being told very strongly by control of infection there was a problem with the environment.
Yeah. Can I ask you to perhaps just offer some reflections on this stage of things? We've already touched on some of it. From your perspective, how did communication with patients work, or rather, how was it supposed to work as regards the events in March 2018?
Well, to be fair to all concerned, I don't think I personally never seen anything like this. In a very long career, this was my first experience of anything even remotely like this. And I think that would go for it would definitely go for all of my colleagues. Communication, as I remember, it came from the medical and the nursing staff mainly. There were handouts, there were things written after IMTs that we would hand out to the families and try and explain what was happening. And the local management, and as far as Jamie Redfern and Jen Rogers, they very often participated in that.
Mm. Can I maybe just summarise what I take from your statement, and you can confirm whether that's whether I'm taking drawing the right conclusions. I think what you say in your statement is that at the start, the information would come in a written statement from management after the IMT had
That
taken
was true,
place.
generally, yes.
Yeah. And this was shared with patients and families. Now, Professor, I'm going to pause there because what I'm going to do is I'm going to give people paragraph references. I'm not asking you to look up your paragraph. It's
I think I have to say about communication, although that's what came as communication from the IMT. You know, you communicated with these families all the time.
Yeah.
And the trouble is, if you don't know what's going on, you can't tell people what's going on.
Yeah. So that's paragraph 152 of your statement. And was it your understanding that we can see from the IMTs that there was often and perhaps always a communications person at the IMT?
I think that, I'm not saying there was always, but there was generally a communication person at the IMT.
And in terms of how the written statement came to be prepared, is that something that you have any direct knowledge of?
No, but I think sometimes I don't think I ever participated in any of the written statements. I might have not about not following the IMTs anyway. Sometimes I think some statements were written by Teresa Inkster. I remember very clearly she wrote about the cladding and the antifungal prophylaxis then, but the comms person would go away to write the statement. I always assumed it was passed by senior management, but, you know, that was an assumption. I don't know for certain because it then just came back to the ward.
Thank you. You say in your statement that your understanding was that it went to board level, but are you indicating that's an assumption, in fact?
It is sort of an assumption. I do remember, you know, they often came on Friday at 6:30 at night, and I remember, you know, it being said, we're waiting for X, Y, and Z to read this. And X, Y, and Z were members of the board.
And another issue I raised just arising from what you've just said, I should have asked you this already. How long did IMT meetings tend to last?
Somewhere between an hour and 2 hours.
And was there an appointed time of day when they tended to occur?
No, I think they just occurred when everybody, I mean, this happened quite suddenly.
Yeah.
So, you know, diaries were filled. So I think they just happened, they would have had core people they had to have present. And they would have happened, and Teresa Inkster was obviously the most important core person. And they would happen with availability.
And in terms of the conclusion, the point at which I'm sorry, let me rephrase that. You indicated that the written statements would come around about 6:30. Did you consider whether there was any delay or anything being held up in terms of the provision of information?
No, not necessarily, because the IMT may not have finished till 4:00. You know, so I think, you know, they were written and then they were checked. So there was time taken for the availability of the checkers. But I don't think they didn't happen in the morning and then they came at 6:00 at night. You know, they often at IMT that drove that statement had often happened in the afternoon.
I mean, just to try and make it, I mean, it is quite artificial, I accept, to try and look at all of this in detail, but not least of all without a detailed bundle of documents from the period. But maybe trying to look at matters more broadly then, just focusing on March, did you consider whether the process of communicating with patients and families was or was not satisfactory at that time?
I think initially in March it wasn't satisfactory. I think it did improve, but I don't think in March it was satisfactory.
And what was it that wasn't satisfactory?
I think there just wasn't enough of it. And I think the families, you know, it wasn't that they didn't want to speak to the staff on the ward, but I think they wanted to speak to people more senior than that too.
So was it a combination of what was being said and who was saying it?
Yes.
I mean, you mentioned that Jen Rogers and Jamie Redfern were on the ward communicating.
Yes.
Are you indicating that people wanted to speak to somebody above that level?
Yes, I think so.
In his witness,
Or have a statement from.
yeah. And in terms of the content of what was being said, what was your impression of the concern that people had about the content of what was being said?
Well, during this time, I think it was believed that she put the filters on the taps and all would be okay. But there were time. But at the end, the bottom line is we didn't really know what was going on. We didn't really know what was, and you can't tell people what you don't know. So I'm not sure how the statements were useful in terms of telling you if you were being prophylaxed or if the water was being turned off or if there was HPV cleaning, going on, or practical things. But I think the families probably wanted to know what was the real problem, and we didn't know what was the real problem.
I suppose if you don't know what the problem is, you can say that you don't know what the problem is.
You can.
And was that something that was said or not said?
The statements tended to describe what was known and what control measures were being put in place.
Yeah. In your witness statement, you say the statements were not dishonest or inaccurate, just written in an unusual style and lacked meaningful information. What do you mean by that?
Well, that's fair. They lacked meaningful information, and they would tell you the water's being turned off, or you're getting HPV cleaned and you'll be moving rooms, or that kind of thing. But they didn't say what the underlying problem was, and that's what everybody wanted to know.
In his witness statement for the inquiry, Dr. Sastry indicates that he thinks that communication underplayed the concerns about the environment. Can you say whether that is I
think that's a fair statement. Perhaps that's why I used a word like, I wouldn't use the word precaution.
Yeah.
Because I think it did. It would be factual, but it put the best emphasis on it that it could.
Thank you. Now, if we move on from communication, Professor Gibson, and just to try and think about the impacts from this period, I emphasise again, I put to one side the question of whether or not infections were or were not caused by the environment. That's not a question I'm asking you. But would it be fair to say, or rather, were there concerns that is what was going on?
Can you say that again, sorry?
I know it was a poor question, I'm sorry. But I'm not asking you whether or not infections were caused by issues with the environment. But were there concerns among patients and among staff that is what was happening?
Yes, I think there was concerns.
Yeah.
We didn't know, but certainly initially that was the message coming out from control of infection.
And were there also postponements of treatment, including transplants over this period? Or
there was. We've talked of putting the filters on the taps. I can't remember the exact lifetime of a filter, but filters were replaced at regular intervals. I think it was 30 days or something, like that. The problem, the issues that were highlighted at the IMT for the transplant patients was that the view had been that the filters would go on and then they would resample the water weekly up until, let's say, 30 days. So they could see the integrity of the filter up until then. But we didn't have 30 days to wait to start the transplant program. So we sampled the water at day 7 and then said, if it's clean or clear or free of infection, we will change the transplant filters every 7 days, because that was the time interval that we knew of the integrity of the filter. Teresa Inkster also felt that, although the company said nothing can get through those filters, whatever their test system in the laboratory might be, we were seeing multiple organs or organisms, and difficult to know if that was comparable to the test system in the laboratory. So cautions were kept in place. By that I mean don't shower, don't drink the water, for the transplant patients longer than they were for other patients because they're the most vulnerable, and their filters were certainly planned to be changed at 7-day intervals until we could demonstrate the integrity of a filter at day 30.
Thank you. And just to mention some other impacts that patients and families spoke about in their evidence, and you deal with this in your statement. One of them is they described it as an increase in source isolation, and you say that's not something that you were aware of.
I couldn't say that with certainty. Source isolation is often done for viruses, as opposed to bacteria. So you wouldn't source isolate somebody because they had stenotrophomonas. So source isolation is generally practiced for viruses. I can understand why the families might have felt like that, because there was a lot of not coming out of the room and a lot of changing, of the room. So every time somebody came in to replace a filter or do something like that, that room was closed down and the families were moved out, and they'd be out, and the same thing happened every time rooms were HPV cleaned. So there was a lot of moving around of the families went on, and that was stressful.
And just overall then, I'm thinking about you and your colleagues, and what was the impact upon morale at this time?
Well, people were worried and morale was low, and I think morale was low because we didn't really know we didn't know exactly what was happening, and had we got the right control measures.
Yeah.
But it was difficult to work in. Families were anxious. You were dealing with anxious families. You can understand why they were anxious. We have drilled into them at presentation that infection is the greatest risk to life. And all of a sudden we're telling them there's now a risk of infection. It is hard to be in hospital for weeks on end, and if you are then not able to shower, you're being asked to drink sterile water, you're cleaning your teeth with something else, that has a huge impact, on families. And I think we were all at the stage of wondering what was going to happen next. Thank
you. Now, moving a little further on in the chronology, I'm going to ask you some questions around the summer of 2018. So I'm looking really at the period May to July, and I'm not going to take us up to the period of decant. I'm thinking really about the early summer. Now, how do you want to do this? Do you want to give me your overview at a high level, or would you rather I gave you what I take from the IMTs?
The latter, please.
The latter. Now, something I should perhaps have said earlier, in doing this, I just wish to emphasise that I'm doing no more than summarising what is written there, that I don't proceed on the basis that the events that are described are proved as having happened. We're just interested in what was being said. Anyway, my impression from the IMTs is that round about mid-May, it was the 15th of May, there was a return, there was a concern about a return of an increase in infections.
That's true, yes.
And I think when you fast forward a little through the IMTs, we do indeed see references to stenotrophomonas. I think there's references to Serratia marcescens as well. We also see that swabbing of drains took place and disclosed various gram-negative bacteria. Yeah. Would that be right?
That's correct.
Yeah. And ultimately, Dr. Inkster thought that at least some of the infections were associated with contamination of drains. Is that right?
That's correct.
And that the advice at the time to the IMT was that this was likely to be a site-wide problem. Is that right?
That's correct.
Now, I think we can also see from the IMTs that there was also a case of a gram-positive infection reported at the time, an atypical mycobacterium.
Yes.
Now, there were further instances of that particular infection the following year, or one, and I'll ask you about that later. There was a concern about showers not draining, which you've spoken about. Is that right? And I think as far as impacts are concerned, the IMTs indicate prophylaxis, additional prophylaxis starting in early June and then stopping a few weeks later. The detail doesn't matter, but
Yeah.
would that be broadly
I
correct?
think that's correct.
Yeah.
Well, the prophylaxis was always stopped when it thought that the control measures were in place.
Yeah. And a return of cases in July, I think, is what's also indicated.
Yeah.
Now, what I want to do, having established that chronology, is really just trying to tease out some of the clinician concerns around that time. Do you recall a point where clinicians indicated that they were no longer comfortable admitting patients to Ward 2A over this period?
Yes, I do. The drains had been swabbed because of a number of infections with Enterobacter and Stenotrophomonas. And as the numbers increased, I think we lost, we were less than confident that we'd got to the bottom of the problem, even if the drains were being cleaned. I'm just struggling to kind of keep up with the different IMTs.
I want to ask you to look at, again, I'm trying to take this in fairly broad strokes and just ask you to focus on particular aspects of things that were said. And one I'm interested in looking at was at the IMT meeting of the 8th of June 2018, which is at in bundle 1, and it's at page 109. And again, if you just look, you've got it, yeah. Should be up on your screen. And again, it's an IMT that you were at. And if we just please move through the bundle to page 112. And under AOCB.
Yes, I see that.
It says, Dr. Gibson chaired a meeting on Monday with her medical colleagues, and asked them if they had any concerns/issues in Ward 2A. They have since come back saying they are not confident we are in control of the environment, as there have been numerous issues surrounding Ward 2A since its opening. Now, do you have a recollection of saying something like that at that meeting?
Oh, well, I think this is perhaps an example of maybe the minutes not being really reflecting exactly what would happen. I would leave every IMT and go and speak with my colleagues and say, this is what happened. And they would ask me, so are we prophylaxing, are we not prophylaxing, and things like that. So that would not at all have been unusual for me to, when it says I chaired a meeting, I think that's rather grand. I probably just spoke to them within the department and said, this is now the problem with the drains, and this is what is happening. And we would have all said that there's just, this is just another event, and are we really in control of the environment, and is this safe? I don't think it was any kind of formal meeting. I probably just got them together to tell them what had happened at the last IMT. I mean, I went after every IMT and reported back.
What do we take? I'll take it. Let's again take this in stages. Is the statement that the clinicians are not confident we are in control of the environment, does that capture what you were being asked to reflect?
Yes, I think I was representing them at the IMT. I was one of them. Sometimes it reads in the minute that I wasn't part of them, but I had the same anxieties as them and the same problem. In fact, our worst job, because I had to go to the IMT, then go back and tell them what was happening at it. I mean, I particularly look at that last sentence, Dr. Inkster, Dr. Gibson and Jamie Redfern are meeting the medics surgeons. I mean, I was part of the medics. I mean, I wasn't part of the control of infection or part of the local management. They'd have come and met me in the same way that they met my colleagues.
Well, I suppose maybe,
I just might have arranged the meeting.
Well, what was the concern? What did not being in control of the environment mean, and who was it that wasn't in control of the environment?
Well, we'd had the problem with water when we'd put on the filters, and that was meant to resolve. the issue with infections. We were now being told there was problems with the drains. And we'd had problems with the shower heads. There had been a sequence of problems that had occurred, and I think it made us all feel that there was a fundamental problem that we were not identifying.
And I mean, does this indicate, though, that we go back to the very start of what you said about the respective responsibilities, provision of care, provision of hospital?
Oh, if you're asking who's responsible to control the environment, I think I've already said that. The responsibility to provide a safe environment lies with the board.
And is this indicating that the perception at this stage was that that was not something that was happening?
Yes.
Thank you.
I mean, the board may act through control of infection, but they ultimately are responsible for providing the environment.
And can you recall at that time what response, if any, you got from the board about that concern that they were not in control of the environment?
I don't remember any response. I mean, I don't know if anybody from the board was present at that IMT. I'd have to go back and look the attendances. I mean, I presume that, Jamie Redfern as the manager would have reported this up to Kevin Hill as the director, who would have reported it up to, there's a lot of reference to an executive group who I'm not entirely sure who they were, at the board. But our way up the ladder was through Jamie, Jamie Redfern to the director and up.
Thinking back to the IMT that we looked at earlier from March, where you and Dr. Murphy raised a concern about the escalation of concerns to a high level in GGC and nothing coming back. I wonder whether you consider that the concern that you're raising here in June 2018 has similar echoes.
Well, it is quite powerful for a group of clinicians to say, we don't think, we're not happy to carry on treating in this environment. There's nothing much more powerful you can say than that to a manager.
But what I'm asking you is whether you feel that that is something that should have been communicated to management at the most senior level, and
Yes.
whether in addition there should have been a response from management at the most senior level.
It should certainly have been communicated up the ladder, to the most senior level. And yes, there should have been a response.
Thank you. Now, my Lord, I'm nearly at the end of this particular chapter, but I noticed the time. I'm in your Lordship's hands.
I'm in your hands, Mr. Duncan. Do you want to take the break now or carry on?
I'm okay.
I wonder if we maybe just go for another 10 minutes. Would that be?
Yeah.
Thank you. I would like to ask you about some reflections just at this stage. And as I said, we'll move after lunch to later stages, in particular, the decant. I'm going to ask you some context, first of all. As at June or July 28, what awareness did you have of risk assessment of the hospital water system that had been carried out by a company called DMA Canyon in April 2015?
Well, I can't answer that for June or July because I can't remember, but I do remember this being raised at an IMT. So the first I knew of it was at some point post-March 2018, but I don't remember which IMT it was at.
And can you recall what it was that was raised, even in broad terms, what was said about this?
Well, what I remember coming from one of the IMTs, there was discussion around how the water might have got infected, for the want of a better word, and one of the things thought was that it might have happened in the commissioning stage.
And what was the relevance of, as you understood it, of this risk assessment report to that? Well,
that was a statement made at one of the IMTs. There wasn't I don't think we heard about a risk assessment.
Oh, I see.
We just heard that that had been one of the things hypothesized.
There are documents that have been provided by the Health Board for the purposes of the inquiry that indicate that in around June of 2018, the quotes identified, close quotes, that a risk assessment of the hospital water system had been done in April 2015, and as I say, was identified in June 2018.
I think I now remember what you're alluding to. I don't know if it's a risk assessment or if it is just routine practice, but the number of viable particles in the water, I think, is that what you're referring to? Had been measured and sent, I think, to microbiology by the company.
Mm-hmm. I think the understanding may be that the report in question indicated concerns about the water system as well. Can you recall whether that was something that was drawn to your attention in relation to the discussion at the IMT that you mentioned?
The only two things I remember from the IMT about that, one was that, water would be sampled, and water has to be tested for Legionella and Pseudomonas even before all of this, so I know other things were added, and there was whatever it is they measure in a total viable particles, there is a limit above which the water should not have the number of total viable particles. That had been sent to microbiology, I understand, in 2015. That was said at an IMT, and was also said at an IMT that one of the possible ways that the water might have got contaminated was during the commissioning processes with pipes, lying around and getting infected and biofilms forming.
Okay, thank you.
But I'm not an expert.
Thank you. And just one other piece of the jigsaw from that time. Were you also aware, or were you made aware of any expert analysis that was done in round about June 2018 of the flow straighteners within the hospital?
No.
You weren't?
I didn't. It was said repeatedly at the IMT that flow straighteners should not be in taps where immunocompromised patients are cared for.
Do you know whether, or did you know at the time, whether an investigation was made of the flow straighteners and that did indeed disclose the extensive biofilm?
Biofilm. I didn't know at the time. I think you sent me that report. Yeah.
Do you feel that that's something that you ought to have known at the time?
Yes, I think in retrospect, yes.
Yeah. Thank you.
But I don't know what, I think we'd already established that straighteners shouldn't have been there.
Thank you. My Lord, I think that might present an opportunity to break.
Okay. We'll take our lunch break now and try and sit again at 2:05.